Thank you very much. Benjamin Dome speaking on robotic-assisted arthroplasty from the American Hip Institute. So some caveats about my perspective. First of all, I prefer the direct anterior approach, but I'm not dogmatic about it. I have done both approaches my entire career, both posterior and direct anterior, and I consider approach and accuracy as two totally independent variables. A further caveat is that due to my specialty in sports medicine and my career treating high-level and professional athletes, I think a lot about the soft tissues and restoring a joint that feels like and functions like a normal hip. So in our endeavor to restore anatomy, we have to achieve normal muscle tension and vectors that make the total hip replacement feel like and function like a normal hip. Now this depends on the restoration of the spatial relationship between the femur and the pelvis in 3 dimensions. And it goes far beyond combined version when we think in 3 dimensions. Now the total hip replacement has been in some ways the orthopedic holy grail. The Lancet called it the best operation of the century in the 20th century. So it is a great operation to begin with, but in this talk we'll talk about how to go from good to great and make our already good results even better than they are. In order to do that, we have to ask ourselves, is there room to improve? We have this great operation. Can we make things even better? Can we do better? Can we improve? I think that we can, and I like to read some of Steve Jobs' quotes. This one in particular is inspiring to me, where he says that he has a great respect for incremental improvement and has done that sort of thing in his life, but has always been attracted to more revolutionary changes. And I think that the introduction of robotics in hip replacement has been that kind of a revolutionary change. So some of the arguments against robotics: I've been doing it this way for 30 years, my results are great, I don't need no stinking robot, I'm just too good. I think that the truth is a little bit finer, and if we open our eyes we can see that there is in fact room for improvement and that robotics is an extremely useful tool that can help us improve. Now, some challenges with conventional total hip replacement. The plot does thicken here because we have used for the last 40 years x-rays to assess how we're doing in hip replacements. But x-rays, and for that matter fluoroscopy, are 2-dimensional views of a 3-dimensional object. And a 2-dimensional perspective of a 3D object is deceptive, just as you see in the illustrations to the right. So the goals of robotics are, firstly, 3-dimensional virtual preoperative implant planning. Second, haptic guidance to achieve the appropriate combined version and hip length and offset. And finally, navigation, where we check the neck cut and femoral version. The ultimate goal is to produce a hip replacement that resembles a normal hip. And again, this involves normal muscle tension and vectors that make the hip feel like a normal hip, and that depends on that spatial relationship in 3 dimensions, beyond combined version, beyond length and offset. Now let's look at the effect just of femoral version on just the gluteus medius force vector. Keep in mind there are 27 muscles that cross the hip joint, but we're going to talk about just one of them, the gluteus medius, and how changes in the broach version or in the stem version will affect the gluteus medius force vector. So you can see in the illustration on the left that if we increase the stem version, we cause a change in the vector of the gluteus medius, which creates an anteriorized vector. And conversely, in the illustration on the right, you see that if we decrease the stem version, then we create a posteriorizing vector of the gluteus medius. So just these small changes change the vectors of the muscles in space around our hip, and that will cause the hip to not feel like a normal hip, if not causing worse things such as instability. Preoperative planning is unique for every single patient. It's based in the robotics on a patient-specific pelvis, hip, CT-based model, and this allows us to customize the plan to the patient's own unique anatomy, which you see happening here. We then do intraoperative registration and plan execution using the robotic arm. The live surgical assessment is essentially navigation, and you see all this information appearing on these screens: the length, the offset, the cup version and inclination, both planned and actual. And when we're reaming, how much we need to superiorize, medialize, or posteriorize our reamer. So it shows us not just our version and inclination, but also where we are translationally in space. And then at the bottom screen, you see the broach version and the hip length and offset. So what does robotics add then? At a very minimum, it adds more information. We have information about cup position, about femoral version, both the native and the component version, and about length and offset, both pre and post-operatively. All of this is more information than we would otherwise have without this system. We also have pre-operative 3D virtual planning, which in my mind is a huge advantage. We are producing a three-dimensional joint, and planning it on x-rays is 2D planning. I think 3D planning is extremely helpful. We have robotic execution, which enables us to be more accurate than we can be with the naked eye alone. And we have navigational confirmation. So an eye-opening study for me was this study out of Mass General by Callanan et al. And this was an excellent study. It was great surgeons, great institution. And they found that fully half of the implants that they placed were not in the safe zone. So we can have a long conversation about whether the safe zone should be the same in all patients or whether there truly is one safe zone that's applicable to all patients. But the fact of the matter is that in this study period, the surgeons were aiming to be in the safe zone and they were only able to get there 50% of the time. So I think they deserve a lot of credit for publishing this very candid study, which was a real eye-opener for me. After the introduction of robotics in our practice, we repeated this study at the American Hip Institute and published this in Core in 2013. And essentially, we compared our manual hip replacements to our robotic hip replacements. You see the gray shaded area is the Callanan safe zone, and the red boxes are the Lewinick safe zones. So either one, we are eliminating the outliers using the robotics. So you can see that essentially with robotics, everyone is inside the box. We then did a larger study subsequently, which was published in the Journal of Arthroplasty on nearly 2,000 hip arthroplasties. And this was a multi-surgeon study where we compared robotic anterior approach, robotic posterior approach, fluoroscopic guidance, traditional replacement, x-ray guidance, and we found that far and away the robotics improved our accuracy in achieving our goal, which for all the surgeons in this study was to be inside that safe zone. So clearly there's an increase in accuracy of the component placement, and depending on the study we look at, this is responsible for up to a 94% reduction in outliers. More recently, we have looked at over 500 robotic hip replacements and found similar results are sustained. We had nearly 90% of the patients in the Lewinick safe zone and over 80% in the Callanan safe zone, respectively. So if that's not enough, then let's go on and look at some of the other advantages. What about bone preservation? Now, because of the accuracy of reaming, we found in this study, which was published in Hip International, that the average cup size used was slightly smaller relative to the size of the femoral head. Or in other words, because of the improved accuracy in reaming, we did not need to take as much bone and achieved good fixation of the cup without over-reaming anteriorly or posteriorly. So this results in improved bone preservation due to the accuracy of bony preservation. And this may be an advantage in preventing periprosthetic fractures. It may also be an advantage if and when this patient needs a revision surgery because they will have more bone stock that has been preserved in the index surgery. Looking further at the clinical results, if we're not convinced yet, we've compared 85 robotic to 85 non-robotic hip replacements at minimum 2-year follow-up, and these were matched cohorts, and looked at the Harris hip score and, importantly, the forgotten joint score. Now, the forgotten joint score sets a very high bar for success and enables us to distinguish between the good and the great because of its lack of ceiling effect. So a forgotten joint score of 100 means the hip feels so good that we never remember that we had a hip replacement at all in any activity that's asked about in the questionnaire. So a score of 80 means we almost never remember. So 80 is still very good. With the goal of feeling like and functioning like we have a normal hip in mind, the robotic hip replacement cohort had more than double the likelihood of feeling like they had a normal hip compared to the non-robotic group, which was very compelling data for me personally. We've then repeated this study at minimum 5-year follow-up, and this was a propensity match in this particular study where we matched 99 robotic-assisted hip replacements to 75 manuals and wound up with 66 per cohort in a 1-to-1 match. And the findings were that in comparison to the propensity score matched manual group, the robotic total hip replacements reported higher patient-reported outcome scores across the board. So that brings us to the last benefit, which is the improvement in functional outcome. So there's been a trend toward outpatient total hip replacement in recent years, and this has been feasible for a number of reasons, including preoperative patient education, a minimally invasive approach, new anesthesia protocols, and accelerated rehab. In my view, the robotics and outpatient hip replacement are in many senses the perfect match, and these go very well together. Now, we do have to consider cost effectiveness because robotics is an expensive and potentially burdensome system. It costs dollars, it also costs space in an ambulatory surgery setting. So you may be thinking that you would like to use robotics, but cost will prevent you from doing so. Now, what we do know is that robotics has proven cost effectiveness in the unicompartmental knee arthroplasty. So what about in robotic hip replacements? Well, this study by Heng et al. Showed that the surgical time was comparable to conventional techniques and the risks were decreased. Specifically, they minimized bone resection with the single ream technique, which decreased the incidence of acetabular fracture, and they had a decreased risk of secondary surgeries for outliers. So putting all this together, it is our contention that it can be cost effective in a high volume setting. Currently, we have a cost effectiveness analysis or cost analysis underway comparing manual to robotic cost, and what you can see in the numbers as they're bearing out was that manual hip replacement was actually more costly compared to robotics from the payer's perspective, both in the Medicare and in the private settings. So in conclusion, robotics may improve our accuracy, improve our bone preservation, and improve functional outcomes. This comes at no increased cost to the payer, and therefore from the payer's standpoint at least is cost effective. From the facility standpoint, a high volume may be required to justify this in the ambulatory surgery setting. To conclude, I do believe that robotics is here to stay, and I think there's a lot that we can accomplish using robotics. I believe there may be other ways of skinning the cat, of improved accuracy and patient individualized planning, which may be coming down the pike. But regardless, our goal should be to achieve a hip that feels like and functions like a normal hip, and to take our results in hip arthroplasty from good to great. Thank you very much.